Hi, I'm glad to be here. I'm Dario Torre, Professor of Medicine, University of Central Florida, and I will be talking about concept mapping, a learning tool for clinical reasoning. I have no disclosure at this point to share with you, so I'm going to go right into the issue of concept maps. So I'm going to describe first what a concept map is. What a concept map is really a graphic representation of a set of concepts that are meaningfully interrelated. And that this interrelatedness, we'll see how important it is in promoting understanding of the meaning among the different concepts. As you can see here, there is a concept map of a concept map, and you are welcome to read through it at a little time if you like. But there's a description of a concept map and what it is. Now, Joe Novak was actually the person, the researcher that in 1984 actually really introduced this issue of this method of this learning tool of concept maps. As you can see, this is obviously just a graphic representation based on a topic where you see actually concept related by linking words. Now, a couple of things I think will be important to understand concept maps and their use, and particularly their use in clinical reasoning, will be some of the theoretical foundations of concept mapping. One in particular is the assimilation theory, which was from Ausubel in 1968. This is very similar to, and it stems from a constructivist point of view, where basically new meaning is actually assimilated to previous meaning by the meaning that is stored in the linked relationship among concepts. I understand that this may be a little wordy, and therefore creating new meaning. So the meaning is assimilated to previous meaning by the interaction and by the meaning, again, that is stored in the relationships among concepts. And that is why the relationship and the linking words, as we will see, are very important in concept maps. Another issue that is critical to the issue of to the use of concept maps in clinical reasoning is actually knowledge organization, which I'm sure you have talked about, and in particular knowledge representation. So knowledge organization is critical for the clinical reasoning process. Experts compared to novices, for example, have very rich, more elaborated, and more organized knowledge. And they're able to actually mobilize, activate, and retrieve that knowledge in a much easier way and more meaningful way. And so in some way, in concept mapping, you will see that the learner uses his pre-existing knowledge as a matrix where actually new knowledge and new ideas is incorporated. Now, when we talk about knowledge organization and knowledge representation, we also talk about cognitive structures and their interrelationships. So the relationships that there are among the different concepts or the different network of concepts. And this is a very important, and we will see, in how concept map can be very helpful to show and demonstrate knowledge organization and knowledge representation of learners. The last part, the theoretical tenet that I think is important to understand here is script theory. I'm not going to describe script theory. I'm sure someone else has done that before. But basically, when we look at a concept map, we also look potentially at how scripts are organized. And scripts are integrated knowledge units that provide an efficient representation. Again, the word comes back again of medical knowledge. So it is very important to understand the nature of links within those clinical knowledge networks. And that's why I think that in a concept map, as you can actually see scripts of different scripts and the connections of different scripts in different parts of the map, whether the map is done individually or is done in groups. So let's keep in mind there's three theoretical tenets, because it will be important to better understand how we can use and how actually we can use concept maps as a learning tool and potentially as an assessment for learning tool. Now, why concept mapping? So some of the things that the research has shown is that the concept maps will foster understanding of a topic, particularly an in-depth understanding, and also will promote integration, for example, basic and clinical sciences. And this could be also very important in the clinical reasoning process. As we said, it promotes knowledge organization, knowledge representation, and critical thinking. Now, concept map can be very helpful also to diagnose, if you want to use, if you allow me that term, how students think when they face clinical problems, and allows to identify knowledge gaps, misconceptions, misunderstandings, and provide opportunities for feedback. Now, in some ways, I like in particular this visual in terms of looking how we think and how we connect different networks and different concepts and different cluster of concepts among each other in terms of as we approach a clinical problem. Now, how would you construct a map? So if we want to particularly, look at how we construct a map and how we actually eventually will communicate this to the student, basically you have a hierarchy that is constituted by a general concept, which is typically put at the top of the map, but it could be in any position. It doesn't necessarily matter. That is eventually that there is a less general concept, and then there is a linking word that basically creates the meaning between the two concepts. And then you may continue to place the concepts and start to develop the relationships and the linking words. Now, an important part is because it's a higher cognitive thinking way of connecting those concepts and what we call a cross-link. A cross-link is usually, it's a linking word, so it's a connection between two different domains of the maps, and even in particular, if you want to be more specific, about two different hierarchies or levels of the map. And this shows a higher cognitive thinking on the part of the student or the students. And so this is how we eventually construct a concept map, and we will talk about some implementation tips later on. Now, this is an example of a concept map. As you could see, this is a concept map done by a 30-year medical student, which is in there when the medical students are 30 here in the U.S. basically are in the clinical clerkship, so they're clinically involved. I mean, and most of their time is spent clinically. So you have dyspnea. As you can see, there is a level. I mean, there is a level, for example, for different cardiac causes, as they're called. I mean, and then there are more specific about what those cardiac causes might be. But what I like to show you here is not only the hierarchy and the progression of the map from the most general concept to more specific concepts, and then so on, is, for example, the presence of a cross-link. As you can see here, for example, you see pneumonia may exacerbate congestive heart failure. Now, this is a cross-link. It occurs between two different domains of the map, and it's a different, and again, a higher knowledge organization and knowledge representation on the part of the student is able to connect the issue of pneumonia as a precipitating factor, for example, for heart failure. So just to show you particularly the role of the linking words in that, and particularly show you what we mean by a cross-link among different sections of the map. Now, another point that I like to make before looking at some of the evidence supporting the use of concept mapping clinical reasoning is the key role of linking words. This is very important because a lot of times we have some differences with mind maps or cognitive maps. It is very important that those, and it's based on theory and on the way that practice has been in the last 25 years in relation to what we mean by a concept map. As you can see in this slide, basically the absence of linking words. So if I were a student, I were to create place a series of concepts within the slides and make it difficult to understand the relationship between concepts. So you have bacteria, beta-lactamase, a beta-lactam ring, an enzyme. So even if we were to draw lines in one direction or another, then we would not have a full understanding of what the student is thinking. And to be honest, most likely it would be difficult for the student actually to actually demonstrate what their understanding is. Now, this is very different than this. As you can see, I mean, here is the same example with linking words. And the linking words provide clarification about the relationship among those concepts, therefore understanding of how the student's knowledge is organized. So in this case, it's bacteria that produce beta-lactamase. Beta-lactamase is an enzyme that breaks the beta-lactam ring. So it's just an example, but an example that is important to look at the important role of linking words. Now let's look a little bit at some of the literature and some of the things that we have talked about. And important to understand this issue of concept maps as an effective instructional strategy to teach clinical reasoning. As you know, and as I'm sure you have talked about, there's multiple methods to learn and to assess clinical reasoning over time in many different ways. This is just one of them. In particular, promoting knowledge organization, therefore the ability of the students to organize their knowledge, and then eventually to develop scripts, and eventually to think about their thinking, therefore their metacognition, and think critically about how the relationships are actually structured. What are some of the concepts and how these are organized together is very, very important for the clinical reasoning process. So knowledge organization and knowledge representation are critical aspects of using concept maps for clinical reasoning. Now, what I like to show also is again this idea of problem representation. So problem representation, what we mean, and we may have different definition, I'm sure, across different groups of different physicians, but we could see it as a sort of a physician internal model of a problem. And based on a number of clinical elements, based on their relationships and their organization. So this is what we mean by problem representation in this case. And now concept mapping can be very helpful to look at problem representation, to explore and examine problem representation. And in a scope and review on clinical reasoning assessment that was published in 2019 by Daniel et al., concept maps have been reported to be a valid educational tool and a valid assessment tool, particularly for problem representation and somewhat also for differential diagnosis, which are two essential components of the clinical reasoning process. So very important to link the idea of using concept mapping, particularly to focus on knowledge representation, knowledge organization, as we said, but also possible differential diagnosis. There might be obviously there are other educational methods that are used in clinical reasoning. Concept mapping may not be, for example, the best tool to look at data gathering in terms of collecting a history, for example, from a patient. There will be other assessments for that. Now, another important idea is also the use of group concept mapping, what we call collaborative concept mapping. And this can be used, again, to explore the group knowledge organization. Therefore, and whether we go into the idea of whether concept maps can also be looked as a instrument to look at distributed cognition may be another avenue to explore. But basically, the cognitive structures and the cognitive diversity of a group of students and can be a very valuable approach for students to get together, to create a map together, and then to learn from each other as they create the map and as they establish the different relationships among concepts. So in this slide, actually, we see that concept mapping could be used in combination with other instructional methods. And in this case, the combination is concept mapping and think aloud, which is shown to be a promising method to foster clinical reasoning and to understand and better provide feedback. So in this case, the student can create a concept map, and then as they are creating the concept map, actually they can think aloud, and you can even get a more in-depth understanding on how they are connecting the different concepts and what is the meaning that they attribute to the relationships across the concepts. And this could be a very powerful tool for learning, for research, and for eventually for assessment as well. Now, this is an example of a concept map done by a group of fourth-year medical students, which, as I mentioned before, these are clinical students. Again, I don't expect you to go through the map. Obviously, this is a lot of different concepts. It's a very rich map with a lot of different networks. But the idea is this was a group map created based on a clinical vignette of a patient, a 53-year-old patient with dyspnea and exertion. And there were basically two potential differential diagnoses, particularly congestive heart failure and COPD, as you can see. Now, as I focus and as I go a little bit more in depth into this map, as you can see, there are scripts, there are emerging, and there is knowledge organization. So you can see how symptoms and signs, for example, or risk factors are actually provided in the setting of a congestive heart failure or COPD. So we talked about basically the ability to detect illness scripts, formation, and how they're linked. Obviously, there is a lot more. There's also diagnostic workup, which is not typical of the definition of traditional illness scripts. But again, you can see how the knowledge is organized, how the symptoms and signs are connected, and how eventually you might not be able to see in this particular slide, but then the map goes into the pathophysiology of some of these disorders and goes into risk factors and goes into the organization of how these, again, how these potential diseases are connected to the main topic, the dyspnea, and to other scripts of other actual diseases. So this is just an example. Obviously, it's one example of a map done by a group of medical students. Now, in terms of concept mapping, we want to distinguish two techniques that you can use. One is what we call high directedness instructor-driven concept mapping, which the instructor really provides concepts for the students to put together. And so you might provide a list of concepts, and then you might ask the students to actually link them and meaningfully link them. Another technique is the one, and some of the maps that I've shown were concept maps, were low directedness, learner-driven concept maps, which means that the learner creates the concept map, whether individually or in group, from scratch, and based on a topic or a focus question. So you can use either one of these techniques, either providing concepts or basically providing topics, and the students can create the concept map. But either of those could be an opportunity. There are differences among the two, but it depends also on your needs. Now, the other part that I wanted to talk to you about was the creation of what we call sort of this clinical reasoning mapping exercise of CRASME. This is a clinical reasoning tool which is a sort of a derivative, if you wish, of a concept map, in the sense that this CRASME is basically presents a cluster of clinical information, of, if you wish, sort of a number of scripts where you have information on multiple disease entities in nodes, in boxes, across different domains. So for the history, for the physical exam, for the next diagnostic workup, and eventually then arriving at diagnosis. And the learners are tasked, and I'll show you an example, are tasked with comparing and contrasting the different information provided in the nodes. And then the nodes are randomly placed within the sheet, and then the students have to connect in an accurate way the different nodes in terms to generate a diagnosis. So let me give you an example of what we mean by this mapping exercise. So in this case, we have a 51-year-old male with chest pain, and basically there are 5 different diagnoses. All these nodes are randomly placed within the screen here. You have the history, the physical exam, the diagnostic workup, but you might have other categories if you wish to do that. And basically, the students have to connect the appropriate node of the history with the appropriate physical exam, with the appropriate diagnostic workup, and then they have to actually write the final diagnosis. So it's not necessarily a matching exercise, but is really more comparing and contrasting and then arriving at a final diagnosis. Now, here we'd like to share with you what I mean by that. So in this case, for example, you have the students will typically start from the history. We have used this for some time now. And let's say, for example, for this acute tearing chest pain, and may connect with what is the physical exam that would be connecting to that. It would be somebody with diastolic murmur. This is somebody with aortic dissection. And so the appropriate physical exam would be the one that is shown here in the first column. And then they connect to what is the appropriate diagnostic workup that this patient, what are the diagnostic findings, for example, in this case, a wide mediastinum on a chest x-ray, etc. And then they will have to write their diagnosis. So they will have to do that for each one of those. And at the end, they will connect all the different nodes, all the different scripts, if you wish, in order to actually arrive at a final diagnosis for each of those 5 entities or 5 diseases. Now, we have also developed an electronic clinical reasoning exercise, because we used to do this in paper, and the students used to, the arrows basically used to place letters, used to place sort of different ways of connecting, of showing their connections. There is also the opportunity actually to, for example, to link this to an EKG. So you might, for example, instead of providing the diagnosis of the EKG, you might actually hyperlink the EKG to an actual image, and the students will have to interpret that EKG along with the rest, along with the rest of the process. And they will have to maybe do the same with a chest x-ray, or you can embed, for example, audio into, if you don't want to say that this, as a diastolic murmur, you can actually embed the murmur, and the student may hear the murmur, listen to the murmur, and then would have to interpret. So this is obviously a greater cognitive experience for the students. I mean, probably a little bit more. You have to watch cognitive load in that sense, so you don't want to create too many EKGs for them to interpret or murmurs for them to listen to. But that could be another opportunity. So the exercise can be very flexible. And this is just an example of an electronic clinical reasoning mapping exercise. In this case, the students can move the different boxes, and they don't have to do any, they don't have to create any arrows, or they don't have to write anything. This is done all electronically, where they can actually move the different physical exam in correspondence with the appropriate history and history HPI in this case, and then the appropriate align it with the appropriate diagnostic workup, and then arrive at a final diagnosis, which they have to enter again. I like to stress that they have to enter the final diagnosis, because usually that is blank. And so they move appropriately in within the history of the physical exam, the diagnostic workup, what they think is the appropriate history, for example, physical exam and diagnostic data for gallstone pancreatitis, for example. This is an actual example of a student completing this exercise, and they have to align that and make sure that history, physical exam, and diagnostic workup are appropriately connected. This is actually very easy to score, and I think has promise in terms of having the students dealing with different diseases and with comparing and contrasting different diseases from with a similar presentation. Now, this is a CMAP software, It's very useful to develop your map. We have used it for many years. It's actually free and downloadable, and you can actually then eventually modify concepts. You can move the different nodes around. It's very helpful for the students because the map is never a static tool, but basically it allows the students also to modify the position of the nodes and modify the links, and it's very helpful and it's very easy to use. And we have used it now for several years. A few tips for implementation, and then I will we'll stop. I mean, I think when you actually, it's important to communicate a few things to a student when you start concept maps, particularly because concept maps could be challenging for students who've never done it before. So, you can start with a concept anywhere in the map. They can place the different concepts, and you can see we used to do it in the old times with actually stickers, and then we used to connect those in the stickers. So create the concepts and then start to see what the relationships are. There's not an ideal number of concepts that the students have to include. It's about what you think, based on the topic, based on the objectives, based on whatever is that you like the student to explore. There is not necessarily a number of concepts. There is many scoring systems, which are not going to describe at this point, but I think it's important to understand that it's how the network is created and how sort of rich the network and the knowledge is organized, as opposed to just a number of concepts. The linking words, obviously very important, but I would not necessarily go and sort of try to understand or try to assess whether the label of the thinking or the linking word is appropriate or inappropriate, or whether one label linguistically is better than another. As long as there is a relationship between the concepts, I think the linking word makes sense. You can stop adding concepts, and the student will ask, okay, when do I stop? Well, you stop when you think your map has addressed some of the questions or some of the issues or the topic that you'd like to address. So basically, when it's demonstrated your thinking and understanding, you can stop. So there is not necessarily a map can go on forever. And we have had also longitudinal map down over time. Explain to learners is very important why using concept maps. Just like any educational method, you want to develop an introductory mapping session. That will be very important. The first map is the most difficult for the student, so they have to be patient. You have to be a little patient in terms of creating, and the first map is usually sort of the introductory map. You can use focus questions to guide map development, but what I mean by that is you can provide the students some more specific boundaries in terms of what you think is important that they need to address in their map. And so again, it could be a clinical vignette. I have done that, but could also be a specific question. For example, what is the differential diagnosis of this particular patient if it is a vignette? But also the why and the how can be very helpful questions that are very important for maps. So why does a patient with congestive heart failure, for example, develop edema? And so the why and the how questions that you can actually create for the students to answer can be very helpful for the students to go into their, to create their concept map, and for you to actually looking at and exploring their understanding of a specific topic. You can also decide whether you want to use the map as an individual versus a collaborative concept mapping. So whether you want an individual or a group of students to actually work together on a concept map. Another thing you could do is, for example, the students, a group of students can create individual maps based on a topic and then get together and actually merge and basically combine and relate the different maps they have created individually into a larger collaborative or group concept map. So at this point, I think I have concluded. I hope there be questions, and I'll be happy to answer them as I can. And at this point, I thank you again for your attention, and I am sorry I cannot be there, but I will see you soon, and I hope to connect on the day of the presentations in order maybe to have a conversation. Thank you.
Thank you very much, and we are quite happy to have you here. I'm really sorry I didn't manage the presentations better, and we are slightly out of time. But except the fact that I will not be able to read to you all the positive comments, like thanks, great tool, and so on. There is one question which pops out several times. When do you think should we start using this?
Yeah, thank you for the question. Can you hear me, I hope?
Yeah.
Yes, I think you can start at any time. I mean, in the sense that depending, the tool is very eclectic. So I think by making some of the changes, we use it with first-year medical students. We use very prototypical cases and very prototypical the whole exercise, has prototypical features of clinical diseases. We use it in the second year. I mean, as the student approach the clinical years, we use also in the clinical years where we start to actually include some EKGs and some X-rays that they have to interpret, therefore whose interpretation is actually not provided. And then we have used it for fourth-year medical students as well. So you can use it across the whole curriculum. And the idea also is that because the tool is eclectic, I mean, I think you can sort of make it more uncertain, a little bit more ambiguous if you want, or create more a typical presentation as the student develops its intellectual and its knowledge and processing skills. You can actually use it at different levels. I mean, and you can also combine it with other assessment or learning tools for that reason.
Thank you very much. Any hint and a suggestion? Which tool should people start with when they want to implement the?
Yeah, sure. You can use it. I mean, with think aloud protocols, we have used it, to have the students think aloud as they solve the reasoning exercise. It could be used also in terms of in other situations with as the students are actually working and collecting a history of physical exam. They could do, for example, a CRASME before before a patient encounter, or at times we also have used it, for example, when we're in Bethesda at the end of three patient encounters, three simulated patient encounters, and we give them the clinical reasoning exercises corresponding sort of to the topics and the cases they actually just saw, and they were working individually and then in groups to actually solve the exercise in relation to the patient encounter they just did. So I think there's a number of things, whether they're simulated or classroom based, or they are in the workplace, that you can actually combine this with. We also combine it with deliberate practice, deliberate reflection, and actually self-explanation as well. So lots of possibilities.
Okay, thank you very much.
Thank you.